For example, if a patient's being paced, it's probably a good idea for us to know that and have our pacer set up and ready to go, rather than, all right, let's move the patient over, disconnect this, and oh, wait, they don't have a heartbeat anymore. If there's a pressor going, if there's some intervention in place, hey, we've got an IV, it's really, really tenuous, or there's an IO, but the needle's sticking out like this much and we haven't been able to put a dressing on it, right? Those are the important pieces. So that if there's something like that happening, that needs to be communicated to the receiving team, because that's something that could immediately affect the ongoing care of the patient.
Yeah, that used to drive me crazy when I was pacing somebody and the nurse all of a sudden's disconnecting things. And you're like, wait a second.
Yep.
We don't need to move them over in this exact second here. Because the nurses don't necessarily, especially in a resuscitation bay, listen to the full report. They're focused on the aspect of care that they are involved in. And same with the techs. They're looking for IVs, seeing if they, they're not necessarily listening to why the patient's here like we are. Mm-hmm. So I think getting them all to be quiet instead of just be task oriented for a couple seconds, looking to what sheet they need to yank the patient over,
yep.
Hold on for 1 second. We can all take a breath here.
Yep. And that's one of the reasons that I specifically say we'll take a report and then move the patient over, is because as soon as that patient hits the hospital bed, what happens?
You're done.
There's all sorts of activity.
Right.
People are scrambling to get an IV in place, undress the patient, get the monitor switched over. There's tons of activity. And what does that activity do to the volume in the room?
Oh, it increases dramatically.
So then what happens to the report that's trying to be given?